Thank you. I'm delighted to be here and talk with this group, and delighted to have this opportunity to talk about some of the positive challenges and achievements done in the Department of Veterans Affairs. I'm really going to focus on team care, and in the context of our workshop objectives here, I guess I also should say thank you to Doug and to my buddy Steve for not having any PowerPoint slides, because I packed twice as many as any rational person should. So fasten your seatbelts. I'm going to move kind of quickly here. So it's kind of in the context of objectives. I'm going to give you an overview of VA's home-based primary care program, that team, what that team looks like, how it operates, and some of its outcomes, and the outcomes expand beyond VA. And then the home health agency, role of home health agency in achieving the triple aim that agencies are, we feel they're complementary and absolutely crucial to our successes. How to integrate home health agency systems into the future, and I want to make a bit of a distinction, what I perceive as an important distinction between integration and coordination, how to facilitate the future of home health care. One area that I'm pretty big on is focusing on the 5% that accounts for 50% of healthcare costs. And Henry's going to talk a bit about coordination and consumer voice, really important. Policy and payment elements, we're going to be covering here some of the, but where do we get to policy and payment that supports teams, transitions, technology, caregivers, and care in alternative settings. And then I'll mention something about research priorities and where I think we have an opportunity and a need for a bit of a, some different methodology for evaluation of some of the marvelous innovations that are going on across the country. To keep this centered on patients, I just brought in with me one example of a veteran who was eventually cared for in our home-based primary care program, a 74-year-old who had really advanced Parkinson's disease and was really struggling with that. Not surprisingly, he was developing significant depression. He'd been falling a lot. He'd had 40-pound weight loss, aspiration problems, dementia, hallucinations. He'd gone through deep brain stimulation, and that did not help, really. Still had serious problems with his gait, with muscle spasms, with tremors and aspirations. After several hospitalizations, the medical team felt like, okay, well, it's time for a transition here, and we'll make arrangements for you to go into a nursing home and receive hospice care. And the veteran said, no, I'm going to die if I'm admitted to a nursing home. So the team took that to heart and changed the care plan, and he was discharged home with home-based primary care and homemaker home health aid services. What is home-based primary care? It's comprehensive, longitudinal primary care delivered in the homes of veterans with serious multiple chronic diseases and disabling conditions by an interdisciplinary team. Take a look at that team. I'm very proud in 2006 we put a mental health provider in every team in the country. As I said back then and say a lot, if we do not effectively manage their mental health conditions, we will not effectively manage their medical conditions. You look at that and you say it's a very expensive team. Absolutely right. But what I hope to bring across is that with the right targeted population, some have said, I've been hearing this for 20 years, as long as I've been doing this, home-based primary care has been a part of my umbrella. We cannot afford that that expensive team. And the message that I've delivered and I hope convey to you today is that we cannot afford to not have that expensive team. They're old in this population that we're caring for in VA. Most of them are male. Pretty advanced stages of disease, a 24% annual mortality. They have on average more than 8 chronic medical conditions. They're among the 5% of our highest cost veterans that we take care of. A number of diseases, and most of them, as I say, have multiple diseases. Half of them have diabetes. A third of them have cancer. 40% have depression. About a third of them have dementia. A lot of lung disease in there. 1 in 5 have schizophrenia. 1 in 5 have post-traumatic stress disorder, really complex individuals. Half of them are dependent in at least 2 activities of daily living, and about half of them are married, but of those who are married, about a third of their spousal caregivers have significant health problems and daily challenges of their own. Longitudinal care, mean duration in home-based primary care is over 300 days, and remember that's with annual mortality of 24%. I'm taking a look at the demographics because this will help make a point further down. This is, years going along, And this is a percent change in the population. So the green line is U.S. total population increase. As was mentioned earlier, the fastest growing sector of the U.S. population, that's that red line, the 85 and older. It has lots of people trembling. How are we going to manage this roughly 74% increase projected over 20 years? What's going on in the VA population? Number of veterans over the age of 85 nearly tripled in half that time, in 10 years. And in fact, doubled in the 5 years between 2000 and 2005. So we've been facing this issue of an escalating older population for decades. We're working really hard to keep up with it. We're still behind, plenty of work to do, and we learn from our community partners. So I took this post at the national level in geriatrics in 2000, and we kind of set up, since that time, we have a little different triple aim. It's close to, Don Berwick's triple aim, but it's a little different for this older population, mostly older, but we don't, I say geriatrics and extended care, I want to make it clear, we have no age cutoff. So we do take care of younger veterans that have conditions that are just, fortunately, not as prevalent until you get older, but we take care of folks who need these services at any age. And so for that population, the triple aim we've kind of pushed for is to increase access, improve their quality, the quality of care and the quality of their lives, and do that at lower cost. So we really want to help veterans remain at home as long as it's practical, as long as it's feasible, and it's what they want to do, with optimal health, safety, independence, and purpose. And we want to do that at lower costs. And a key part of that success is really to focus on the 5% that accounts for 50% of healthcare costs. It's, in any healthcare sector, it's pretty close to that. In VA, it's really 7% and 54%, but 5% and 50 is easy to remember, and that's about what we want to do. And I really work hard to get my folks to not focus on the 50% of the healthcare, 50% of our population that accounts for 4% of our healthcare costs. Most anything you do in that group, you're likely to raise costs. So we're really having a big effort to shift care into the home. It's really important when I talk about home-based primary care that we understand the distinction right up front between home-based primary care and routine Medicare home care. They're different and complementary. Different target population, different processes, different outcomes. But we really need to work together as a team. Some of the differences here, kind of to put them out clearly. Home-based primary care, we target people with complex, chronic, multiple comorbidities disease. Medicare home care was designed for really post-acute kind of single problem intervention, a focus on remedial conditions that get better. And we're comprehensive. So we're going to take care of your diabetes and your depression and your dementia and your arthritis and your visual impairment and your need for a ramp, and we'll do all of that. When I took this job, I rewrote a couple of policies. One of them was hospice, another was home-based primary care, and I wrote homebound status out of our policy because I felt like this is not going to help us get to the population who really needs this care. This is going to be a limit, a barrier, and I think it has served us well since then. And we, I think our folks are doing great if they slow the decline. So we do not require any improvement in that status. We work for that, and there are some things that do improve, but that's not a condition of participation. It is an interdisciplinary team as opposed to multidisciplinary. So these folks work together as a team, they meet as a team, they create a single unified care plan as a team, and I think that's really important. It's longitudinal as opposed to episodic. The reasons we bring you into home-based primary care generally do not go away. So you're likely to be, we're likely to be your care provider for the remainder of your life. And we do have significant and growing data to show that we have an impact in reducing hospital days and reducing total costs. I think there's some discussion here that's valuable about, does that happen with Medicare home care? And I believe that yes, for certain sectors of the population that receives Medicare home care likely reduces their cost of care. But on a global sense, I think that's not been shown. On the other hand, in VA home-based primary care, we have limited geography, limited intensity. We really, we're not designed for post-acute care. We're not designed to be in the home frequently. Medicare home care can get anywhere for us, and they'll be there, pretty much any time, multiple days in a row. So it's a very complementary system. We have to work as a team. Back to this case, so the interdisciplinary team worked with the veterans, caregivers, educated them. Education is a huge part of that. The social worker helped to integrate with the community and community services, veteran-directed care, which we have in over half of the states. That's that person-directed care. And the rehabilitation therapist really helped kind of that emphasis on the move and get this person up, get them into some exercise that fit them. When I came to Washington in 2000, one of my 5 goals was I'd been a medical director of home-based primary care in a facility in Columbia, Missouri for a decade. And I really felt strongly about this program, and I wanted to see it move into Medicare. And that was one of my 5 goals coming to Washington. A couple of years later, I met a few folks here in Washington at a conference, I think it was George Washington University, at a symposium, that were very like-minded, and I think they're all in the room today. And I said, wow, you guys are working on this same thing. Can we get together? And so there's been a half a dozen of us renegades that have been working on this and pushed hard. But one of the things that, we each had a role. My role was to, what can I bring to the table here for VA data? And VA had some pretty strong data for demonstrating the impact of home-based primary care. And so we designed a national analysis to look at that, and it's an ongoing steady part of our reporting in VA home-based primary care. But that 2002, it's a pre-post analysis, so it has its flaws. We've done some adjustments, but I think we have pretty strong evidence that this is more than a regression to the mean effect. But we did see substantial reduction in hospital days, nursing home days, and a 24% reduction in total VA costs of care. VA really believes in this, so we've grown from when I came in to 7,000 to now we're in half of medical centers in the country. Now we're in every VA medical center in the country, and we've grown from 7,000 to over 34,000 veterans every day in home-based primary care. We're continuing to grow. We're about halfway there from my perspective. And we're reaching out into rural areas. Veteran population, about 40% of them live in rural areas. We're getting close to meeting that map of where they live. But an important question came up as we were working with the members of Congress, Wyden and Markey, and I was anticipating this question. That data, Dr. Edes, that data looks pretty good about VA, but what's happening to their Medicare costs? Are we sure that maybe when they get really sick and they need expensive care, how do we know you're not shifting them into another system for health care? Because that's a possibility. So Bruce Kanosian and others in the room, Peter Bowling, worked to design some methodology to take a look at this and answer that question kind of squarely. I called the Medicare Medicaid Analysis Center and asked if they would help, and they jumped right in. It was phenomenal. And so using hierarchical condition category score is a methodology that's used in CMS to project costs for programs like PACE. We applied that in this model, and here's kind of the essence of what it showed, and that is in each category of complexity or hierarchical condition category score, the predicted annual cost, red, was higher than what we actually saw for those who were in home-based primary care. So I think that really helped us. That helped convince a lot of people in Congress and different areas that needed to be convinced that we did have a model that impacted, and it really was saving dollars, not shifting. It was really saving dollars, because what this showed was veterans in home-based VA's program, at the same time they were enrolled in Medicare, they experienced a 10% drop in their Medicare hospitalizations, 10% drop in their Medicare costs. And so collectively, that was a 25% reduction in combined VA plus Medicare hospitalizations, 36% reduction in VA plus Medicare days in the hospital, and a 13% reduction in combined VA plus Medicare costs. So back to this individual, what do these team members do? Well, the provider and the nurse really helped on educating through some of the complicated management. I really love the kitchen table thing. For 20 years, I've been saying the gold standard of medication reconciliation happens at the kitchen table. That's where you find out. They'll bring their bag of 8 or 9 medications into the clinic, fine. You get out into the home and you see where they really keep them. It's in a fruit bowl. And there's a lot more pill bottles there, and some of them are pills that they've swapped with their neighbor. So you really need to know that stuff, and that's why you need to get into the home. The dietitian, this person was very complicated in the aspiration risks and didn't like the taste of commercial thickening products, so worked with him to really help that and support his weight goals. The psychologist addressed some very important problems for this person, and the whole team worked to continuously find solutions as problems emerged. And what's happened? Well, so he's, from his perspective, a really remarkable improvement in his health. And, far fewer falls, his weight had stabilized, his quality of life from his perspective had really improved. He really felt much more engaged with the community. Hospitalizations dropped. His goals were met. He was not in a nursing home. He was at home. He did not have a feeding tube, a peg, or anything like that, and he was more active and engaged in the community. So yeah, this cluster of renegades in the room here, and members of Congress who were very supportive. I think Jim Piles says that this is a rare event in which you have what's the word? Unanimous bipartisan support for this bill. Pretty rare event. And so this did get signed in the Affordable Care Act and established not only the model, because the model from some people in the room who were doing this outside of VA in isolated pockets of excellence, it was there, but very small, on a small scale, because the economic structure of Medicare did not support it. And so it was both the model and the economics to support it. It's very similar to what I've just been talking about, targeting chronic disabling disease, and it's an interdisciplinary, longitudinal, driven by people with geriatric skills. You have to have an electronic health record. Quality and the individual satisfaction are key drivers here. The outcomes we're striving for: fewer hospital days and cost savings. The first 5% goes to CMS. The next bit of savings is split between CMS and the provider team. So some great folks were selected for this, 16 sites and 3 coalitions. It's in the 3rd and final year of the Medicare demonstration. The American Academy of Home Care Medicine has been working and has established a training program ready to serve when this opens up and there are more folks out there who want to provide this kind of care. Another analysis I just want to point out, recently published in Journal of American Geriatric Society. Eric DeYoung, George Taller, and some others did this great work, and so it evaluated their practice that they've been doing for years, providing service to mostly frail older individuals in the Washington, D.C. area, but also some youngsters. And it is a team. It's that interdisciplinary team. They did a 5-year case control study that was propensity matched. So a nice model of healthcare. It's not randomized controlled trial, but it's a very robust model. They looked at about 7,000 people that they had taken care of and 3 times as many controls. And in that 2-year analysis demonstrated a 17% reduction in total cost of care. Of course, higher home health costs, higher hospice costs. But that's what you expect, and that's really bringing the care into the home. So there are conclusions that HBPC does reduce costs for targeted individuals selected, and part of that was when they took a look and stratified them by frailty. The savings were only in that highest frailty group, so again emphasizes the importance of targeting. The savings beginning only after 6 months, so also emphasizing longitudinal care. And it really supports this. And looking at the big picture economics, they suggested that, well, if you look at Medicare population, 50 million roughly Medicare recipients, and at 3% of them, that's 1.5 million. If you save what they projected, $4,000 a year, that's $6 billion a year. We could use that. So we have a publication that's about to come out this month, also in Journal of American Geriatric Society, evaluating the VA's home-based primary care program and its impact on VA and Medicare. And so it's a lot of what I've shown you here. But we put a statement in here. It is a bit of a plea saying that we need robust methods of analysis in addition to randomized controlled trials to meet the challenges of what we're doing in these kind of innovations. We're evaluating complex interventions. HBPC is not a simple take this pill or do this exercise. It's very complex. It's in a very diverse population. Multiple comorbidities and variable comorbidities and combinations of comorbidities, and they're receiving individualized care. It's not you're all going to get this. It's very individualized care, and it's in a rapidly evolving healthcare system. That really is a mess for randomized controlled trial. So we do need some methods, and I think people are working this. I mean, just a couple of minutes here, closing up. I want to talk about medical foster home. It's another example of the importance of teams. Medical foster home. Oh, and this right here. So when you get this in your email, you might want to click on that. That will take you to NBC Nightly News and a 3-minute video that I think you'll find very heartwarming. It's a walk into the home of one of these individuals and the people taking care of them. So it's a medical foster home is an alternative to nursing home care in a personal home at about half the cost. And it merges the adult foster home concept with an interdisciplinary team, home-based primary care. It's going to come in, it's going to educate the caregiver very specifically about this individual, what does this person need. We help with home modifications if needed. So we do all of that, but what it really hinges on is finding someone, I call them an angel in the community, who is willing to open up their home and heart and take in a veteran. And the idea is you're going to take in the veteran for his or her, the remainder of his or her life, for the older ones. For younger ones, we kind of suggest about a 3-year pattern that's renewable and work on that. But the Wall Street Journal captured it very well. They put an article in, they considered it one of the 10 top healthcare innovations. And happier veterans, lower costs. That's what happens. This is one of the first veterans in our pilot project in Little Rock, Arkansas, or Hot Springs, Arkansas. And if you ever get a chance to enter one of these homes or visit one, you'll see why I called this medical foster home where heroes meet angels. And it's not just about older veterans, so we do certainly have younger veterans being served in this program as well. So a couple of things to make some points here. So between 2000 and 2005, CBO, Congressional Budget Office, did an analysis a few years ago looking at 1998 to 2007 and 2005, and in those 7 years found that Medicare costs per patient rose in those 7 years 29%. In VA, 2%, much lower cost of increase, attributable largely to VA's development of programs specifically for persons with serious, complex comorbidities, many of whom are homebound. This population we're really focused on. But so what happened in those 5 years when the cost, total VA cost per patient rose very, very little? Our VA paid home hospice increased over 400%. I was pushing in a lot of ways to make some changes in our system. The inpatient palliative care grew 25-fold. Palliative care team consults increased 21% a year. Home-based primary care increased 55%. Medical foster home nearly tripled. Our compendium, our spectrum of home and community-based services increased 87%. So we put a lot of money into these things, and look what happened. Or still, during that time, only a 2% rise. I'm just going to touch on hospice and palliative care. It's a big passion of mine. Landmark year, last year, more veterans died in our VA hospice inpatient units and died in acute care and hospital care combined. Also, Steve mentioned, a vision of going from about a fourth of our population dying at home to double that, about 50%. So veterans in home-based primary care and medical foster home, about 2/3 of them die at home. Okay, so global picture, what's going on in VA? The green line there is the number of veterans receiving VA-financed nursing home care. And focus on this period between 2000 and 2010. That's when the number of, so what happened? The number of veterans in nursing homes increased about 30%. Yes, it increased about 30%. Remember that early graph? What happened to the number of veterans over the age of 85? Tripled. How did we achieve this? I think it's because the purple line is our increases in home and community-based services and the teams behind them and the teams in the VA and coordinating with teams outside the VA. So my last couple of slides here. What do we need to do to strengthen and integrate teams? Because team care is really crucial here. For this 5%, there are a number of things. I think we need to work together for all of these, the personal support services, caregiver support. Really, the caregivers are absolutely essential to making this work. The longitudinal care we need, palliative care, not just hospice care, palliative care that spans all settings. And we're working hard to do all of these things in VA right now. Optimal use of hospitals and nursing homes and assistive technology that spans all settings. We're working on a transitional care program in VA that is to be integrated. And the difference between integrated and coordinated to me is like the difference between multidisciplinary and interdisciplinary teams. So integrated means presence. That transitional care team is going to meet with the clinic folks and get to know them, get to know the patients there. They're meeting when the veteran gets admitted to the hospital. They're going to be there and meet with the admission team and touch base with them through and be a part of the discharge process. They meet with the palliative care team and the community hospice agencies and our telehealth coordinators. They get to know the nursing home staff. They know all of them. They work with them, and it's more than coordination. It's integrated, but that really helps achieve successful coordination. So can we increase access, improve quality, and lower costs of care? I say we are. We are doing that. I've demonstrated that, I hope, on 3 levels with home-based primary care, medical foster home, and palliative care. We can do better. We really can do better, and I think largely it's going to be through teams, and it's all of us working as teams, working with teams that are a bit, fragmented right now. But the more we can work as teams, the better we will impact the lives of the people we take care of. Teams, technology, transitions, and integration. So a number of things here that I've listed. These are things that we're working on, and I think we all can work on. So technology piece in VA, we need it. We have our home care providers, this team going out to the home. And I said, we got the best, one of the, a really strong electronic health record. I can go into Baltimore and somebody comes to me from Spokane, click, I got your records right here. And, as Warren mentioned to me when he was talking about experiences in New Orleans, he said it was great. Katrina, those veterans, wherever they went, their healthcare record was right there. It didn't matter where they went in the country, where they got dispersed to, their healthcare record was right there. And anyway, we have that record. We get out in the homes. We're taking care of some of our most medically complex individuals. We have no record. You can say connect with the internet, not reliable. Can't reliably get to wherever we are. We're in a lot of rural places. And so we created a software package, and so now we have in that laptop all the veterans' records, 12 months, all their labs, their x-rays, the x-ray reports, their laboratory, every clinic note. It's all in there, and you can enter your notes. So it's, I think, those are the kind of things that I think really where technology really can help us. Hospital at home, we really need to grow that, but and for that and all the home care shift, more point of care diagnostic testing. So unsustainable rise in healthcare costs. I'm trying to push this message. In the context of unsustainable rise in healthcare costs, I'm concerned that many people across the country in influential places see this population with multiple chronic disabling diseases and these long-term care services we provide as the problem. That's the problem. That's the source of our unsustainable rise in healthcare costs. I see that very differently. And so I would like to convince people and really change that thinking to these services that we're all here to really improve upon. The spectrum of services are integral to the success of the unsustainable rise in healthcare costs, because we know we can drive healthcare costs for this small part of the population that accounts for most of our healthcare costs. Focus on the 5%. So I just want to leave you with this. Who is in that 5%? And in my work with folks in influential places in healthcare systems, I have a concern that some of them see that 5% as that's a small, marginalized, disadvantaged group, and we can kind of take, we might ignore them. We've really got these other things we need to take care of for more people. But what I want to emphasize is that's not some small, isolated population. That 5% represents nearly every one of us and our parents and our children at some phase of our lives. So that's personal. Let's take it personal, and let's get together and work as teams to take care of business. Thank you.